The information in this podcast is provided for informational purposes only. You should not use any information discussed in this podcast and related materials to make medical or healthcare related decisions. Always consult your physician or other qualified healthcare provider with regards to diagnosing and managing your medical condition. Any medications or treatments, including any discussed in this podcast, should be initiated and managed by a qualified healthcare professional. Welcome to Long COVID The Answers. Today's episode is entitled The Psychiatric Management of Mental Health in Long COVID. This interview is part of our neurological Long COVID section of the series. I'd like to introduce you to Professor Thida Thant. Professor Thant is an award-winning consultation liaison psychiatrist and director of the University of Colorado Hospital Consultation Liaison Psychiatry Service on the Anschutz Medical Campus in Aurora, Colorado in the USA. She is also Assistant Chief of Service for Colorado University Medicine Psychiatry Community Practices and Director of the Psychiatric Consultation for the Medically Complex Clinic at the University of Colorado, where she provides rehabilitation for long COVID survivors. Welcome, Thida.
Thanks for having me. I know my introduction's a mouthful, so I appreciate it.
Thida, do you have any conflicts of interest to declare?
Yeah, the main things I have received speaking honoraria from a few different hospital systems in the US talking about this topic. And I do get some grant support for long COVID research from NIH and from some private donors to the university.
Great, thank you. Thida, firstly, could you tell us the difference between a psychiatrist, particularly a liaison psychiatrist, psychologist, and neuropsychologist?
Yeah, I think that's a great question because obviously a lot of COVID centers have some mix of the three. And so starting with myself, I'm a consultation liaison psychiatrist. So a psychiatrist is a physician, went through medical school and residency to focus on disorders of the brain and emotions and the psyche. And then within that, there's some subspecialties. So consultation liaison means I chose to pursue a fellowship in medically complex patients, basically, and that overlap and intersection between our mental and physical health. And then you have psychologists who are experts in evaluation and therapeutic management of mental health disorders. And so they often focus on things like therapy, diagnostic evaluations, things like that, but don't prescribe medications in most places and didn't go through medical school. And then neuropsychologists, specialized form of that. And so those are therapists and psychologists that really specialize in the brain, how brain injury affects functioning, cognitive testing, and how all those pieces go together and how to manage and rehabilitate brain disease. So that's how all three work together.
That's a fantastic answer. Thank you. Great clarity there. Could you tell us about the Psychiatric Consultation for the Medically Complex Program, or PCMPC, that you direct? Why was it set up and how it provides rehabilitation for those suffering from long COVID?
Yeah, so many psychiatrists like myself often work in hospital-based settings. We tend to work on medical floors, and we work with all sorts of patients that have really, again, this complex intersection. So maybe they just got a transplant or need a transplant, or maybe they have a neurological disease that causes psychiatric symptoms, or maybe they experience things like steroid-induced psychosis, whatever it may be. And we have lots of specialists that see them on the inpatient side. And then when they get discharged back out to the community, there isn't as many places that feel comfortable managing those kind of diseases. So that's where the impetus for this clinic came from. It was made by a predecessor before me and really focused on helping these patients transition out of the hospital. And then when I joined faculty back in 2018, I got to take over that clinic and worked on expanding it to take referrals from many specialists within our hospital system and many patients from the community. And so that's how we ended up treating like transplant patients, neurological patients, and all of that.
How do you provide rehabilitation for long COVID survivors?
I got approached shortly before the pandemic by a pulmonologist who already had interest in my clinic because she was getting ready to work with post-ICU patients. And there's a lot of neuropsychiatric symptoms that come from that. So we'd already been in discussion, and then the pandemic hit, and she was pivoting her clinic because she started to realize there was going to be a lot of patients who needed higher levels of pulmonology and critical care things outside of the hospital. And so she asked if I would do that with her, and we started to share patients and just try to learn together to figure out how to support folks going through this. And so my clinic really focuses on the mental health component. So that's like diagnostic evaluation, treating neuropsychiatric symptoms through medications or psychotherapy, and helping arrange referrals sometimes to other specialists as well. And so that can be referrals to sleep medicine, cardiology, or speech therapists to help with cognitive rehabilitation.
Yeah, you forget as a physician how a huge range of diseases, when you're hospitalized, can affect your mental health, whether directly or indirectly, whether it's through the trauma of going through the disease or whether having the disease affects how your brain functions and therefore leads you to develop psychiatric illness. I'm amazed that we don't have those types of clinics everywhere. Could you please tell us what proportion of your patients are long haulers?
Yeah, so as you can imagine, my clinic's pretty small. And so I would say during the peak of the pandemic, probably half to 2/3 of my clinic was long haulers, but I still had other patients too that needed care. And so we've been refining our offerings, really trying to hone down what's the part that really needs to happen with us and what's our specialty, so to speak, versus what care can happen in other parts of the system. And so now it's probably a little bit closer to a quarter of my patients. At times, still approaches have. It's still a huge percentage of my clinic, but we specifically are a medically complex clinic, so I'm trying to provide care for everybody that needs it.
So how many patients do you have in the clinic as a whole?
Oh, that's a good question because it is a training-based clinic, and so there's multiple caseloads going on. I think we often have, at any given time, maybe close to 100. I have problems quantifying because we are, as we've talked about before, I'm a short-term model. So we have lots of new patients come in and out to try to consistently stay open. So it's challenging. I work with 2 to 3 residents at a time for one half day. So on any half day, we can really only see maybe 8 to 10 patients given their complexity. And then I have a psychologist that works with me as well. So she has a full time caseload and we run multiple groups. And so I think when you add all those numbers up, we get close to trying to evaluate 100 plus patients per year, but it's hard to say.
So what's the wait time to get into your clinic for long haulers?
Yeah, it depends on the time of year. So this time of year, as we get near the end of our academic year, we're pretty full. And so it can be several months to get in. Other times of year, I do try, that's part of the short-term models. I really try to get people in within 1 to 2 months. But I think I do average 2 to 3 months to 4, depending on what they're coming in for. If it's group versus just evaluation versus therapy.
Do you know the size of the population you're serving?
Oh gosh, I mean, it's thousands when it comes to that, because even if you just look at rates of COVID across the US, in Canada and other places, so much of the population has had COVID, right? And then we're noticing that a significant portion of the population can go on to develop some form of long COVID. It may not be debilitating, it may not be multiple organs, but a lot of people experience something, whether that's some brain fog, whether that's feeling their mood just isn't going back to where it is, or feeling fatigued. And so the population that needs and wants to get in to see me is thousands and thousands. And then our capability between the COVID clinic and myself is much, much less than that.
Yeah. Thank you. That's great. You talked about the time limit on attendance to the PCMPC program. Given that long COVID is looking like a long-term chronic illness for a significant proportion of sufferers, what are the aims and objectives for attending your program?
We really focus on the evaluation and brief initial treatment. Because what I started to discover was that many people in the community just didn't even know where to start with patients coming in with these struggles. And given my background and our expertise in medical complexity, we're able to sit down and really think about, okay, what are all the things happening? Long COVID may be the main thing, it may only be a part. Or maybe you have pre-existing conditions that are getting exacerbated by your COVID experience or COVID infection. And so that's really the part we try to focus on. And then once we've developed what are the main diagnoses going on, what are the main needs, we will often initiate the first part of treatment and say, you're having this depression. A part of it may be a psychological sequela of your illness, and sure, part of it may be neuroinflammation. Regardless, we'll start treatment for depression, right? We might start therapy, we may start medications, or I might be like, you have a sleep disorder, let's get that referral going. You need cognitive rehabilitation, let's do that. Or maybe, I'm not sure, we need some extra testing. And so that part can take quite a while, actually, and fits our short-term model. And usually once we've identified that and started to go down a treatment path, we can partner then with either general mental health practitioners or family medicine or general practitioners or whatever it may be to continue on or maintain treatment. So that's how we do that. And long COVID, it's interesting because it straddles that line, I think, with acute and chronic illness, where for some folks, weeks to months, maybe 6 months, and then back to themselves. And other folks we're seeing in studies say a year or longer. And I have seen that in my clinic. But many of them do have improvement, whether it's resolution or not is different, but they often have improvement. And so we find that they can go back to the community. And then if they get a reinfection or something changes, they can come back for a reevaluation and we see if something's changed. So that's how we handle the chronicity in my clinic. And then we do offer some longer term aspects of our care, like our group therapy has historically been long-term to give a place for people to continue to have support while their disease progresses.
Right. So what time period do you actually work on long haulers in your clinics, sorting all of that out? Because that sounds great. It sounds like you really have your physician hat on as well as your psychiatric hat on when you're managing them.
Yeah, we try. I have really good partners in other specialties as well. And our COVID clinic is very multidisciplinary, and that's important. But I would say on my website, we talk about 1 to 6 sessions. It's somewhere in there because, again, it depends on your needs, what the patient even wants. Some folks just want to come in and have an expert look at them, and they're like, okay, I feel better. I will work on rehabilitation. I will work on my functioning, my goals of care. But I just wanted to make sure there wasn't something else I was missing. And so some folks are happy with 1 to 2 sessions. Others will do up to 6, and we try to have that span maybe up to 6 months.
Oh, right. So it's
End.
about 1 session a month.
Yeah, about 1 session a month. And again, because we're often adding other forms. And so psychotherapy will be with someone else in groups. And so they may be getting more appointments in that. But with me, it might be, and my residents, it might be about once a month. And then some patients we keep closer to a year. Again, it just depends on what's happening in their treatment plan.
So do they self-refer or are they referred by their family physician, or do you take some of them from the ICU or hospital? How does it work? How do they get into your clinic?
Yeah, it's been a combination. So my website does allow self-referrals. We have started to, because again, of the demand, for some of the self-referrals, we said, look, I can see you once and do a really good evaluation, and then we'll talk about next steps that may or may not be in my clinic. I do take the referrals from our multidisciplinary COVID clinic. That's where I prioritize it because that way we can all work together. And those are usually even higher complexity cases. And then we've been trying to train up other clinicians in the general larger clinic that I'm housed in. And so a lot of them stay in that general clinic, but those clinicians can consult with me. And so we're trying to improve and increase the kind of competency in the general mental health population because, again, the need's so high. And then I do take cases from my inpatient service. So they message me and say, here's why this case would really benefit from your clinic. We try to get them in. And so over the years, I've taken it from everyone. I definitely take referrals from other doctors and other specialties. And we flex that based on how full I am, honestly. And so some people will come back in 3 months and say, I'm asking again. I'm like, great. It's great timing. I can get them in.
Great. Okay. Could you please talk about the different mental health conditions that occur with long COVID and what symptoms doctors and long COVID sufferers should look out for?
Yeah, there's a lot, obviously, but I think things I most commonly see are depression, anxiety, symptoms of medical trauma or PTSD, and sleep disorders and cognitive issues. Those are sort of the top things that people tend to come in. And it's complicated because with the depression, it can be a couple different things depending on how severe their illness was, depending on their medical comorbidities. Their depression may be a combination of the physiologic impact of the illness combined with, as I mentioned before, the psychological sequela. So what is it like to have gone from someone who was super functional, super active, because I'm in Colorado, right, to someone who could barely get out of bed? And there's a lot of obviously emotional toll of that. And so we can see that mix, or anxiety about getting ill again. Or if they were someone who was very ill and was in the hospital, in the ICU, fear of dying, again, if they get sick. And then I mentioned medical trauma, and that was very true, especially in the early waves when patients first started coming to me, just being in the hospital and not knowing, because seeing everything in the news about how there's this new novel disease that no one knows how to treat and people are dying from it. And so many people were highly traumatized by that, or just, even if they were receiving excellent medical care, it's really scary to be in the ICU or be in the ER. And so those are some of the big things. And obviously like brain fog, which is something that straddles multiple specialties, kind of neurologic, psychiatric, And so that one is, I'm lumping it in this question of mental health, but actually it's arguably larger, more comprehensive than that. But we know that many mental health symptoms and conditions can worsen cognitive functioning. So that's part of the evaluation I do too, is try to figure out how do we optimize all parts of your care to try to improve some of the symptoms that are just going to take a while to get better.
Mm. Okay. And so what symptoms should doctors and long COVID sufferers look out for? 96% of mental health is managed in the community by family physicians, and I'm sure they're managing a lot of sufferers. So what point are they going to need your clinic? What sort of signs would you say that they need that extra help?
Yeah, and I think, yes, you're right. GPs and family physicians handle so much in their clinic. My mom's a primary care doctor, a family medicine doctor, and I see it, right? I think many of them are very comfortable initiating first steps. They can start an antidepressant, they can refer for some forms of therapy. And I think that makes a lot of sense. Where you start to wonder if they need to come to like my level of care is like, hey, these early steps are doing nothing. Or maybe I'm not even really sure how all these pieces fit together. My patient keeps coming back. They're obviously suffering. They're having significant impairment in multiple parts of their life from this. Like they can't work. Their social relationships are suffering. Their physical health is suffering. And I think those are ones where when you've ruled out the things you feel comfortable, and that can vary from doctor to doctor, but you're making sure you're not missing classic conditions. Because I like to remind people that long COVID, other things exist, common things exist with long COVID. So you can have long COVID and addiction, or long COVID and COPD from your tobacco use, right? You can have all these things, so trying to work those parts up. But again, you're scratching your head. I treated all those other things the way I always do, but really they've had this worsening since their COVID infection. It's not getting better. And I think then it's perfectly reasonable to try to seek consultation at minimum to make sure there isn't something else that we're not sure about. Or I think another area is we've had some physicians who are just, well, I've never heard of that, so there's not really anything to do. And I think if that's happening in the wake of a COVID infection and they meet the kind of time criteria for long COVID, that would be another time to seek it out. Because I think we have found, for those of us that have seen this in concentrated forms, we're like, actually that weird symptom can be seen in long COVID. And again, even if we don't know how to treat it, that itself is very validating to the patient to know, yes, the symptom comes from somewhere. I'm not making this up. And so that's why I tell family practitioners to look for is like, when is it exceeding the workup you know how to do for the symptom in front of you? When it exceeds the medications you're comfortable prescribing, that's a good time.
Okay. Your assessment is thorough and broad, and you take into account a lot of the other symptoms that long haulers are suffering from. So you don't feel that every long hauler needs that type of assessment, or do you, and there just isn't the service?
I think somewhere in the middle, probably. So I think there are a lot of folks with long haulers where it's, I hate the word milder, but it's milder. They're kind of like, it's getting better. Yes, I had this for 4 months out, but I can feel every month that things are improving. Those folks really may not need us, because I've actually had a number of those when they finally get in to see me, I'm good. And they're like, yeah, I was really suffering when I got referred, but now it's been this many months and actually I'm doing pretty well. I don't need anything. I came because I wanted to see, but because they're a conscientious person. So that shows you that there is a self-limiting nature to this at times. It can resolve, but I don't think those folks need to make it in, but there are folks who really aren't getting better despite optimizing their physical health, despite going to physical therapy, whatever their needs are. And I really think those are the ones. Again, this is becoming quite prevalent. And I do think every medical professional should be trying to figure out some base level of competency. That's why I think things like this program, or there's the ECHO series that we do. There's resource documents we've put out, the American Psychiatric Association, consensus guidelines. It's really important for everyone to read that, because it is going to show the way we talked to primary care and said depression's going to show up. So you have to find a way to develop some level of confidence with it. I do think long COVID's reaching that point. And so that everyone needs to be familiar with it, have some idea of how to approach it, and then that way use higher levels of care for when that fails. That I do think we're reaching that incidence rate.
Oh, I think, yeah, we reached it a long time ago. It's just that the medical profession is just so slow. That's why I'm doing this. But
Yeah.
fantastic points. Thank you. How do the mental health disorders amongst long haulers differ from the increase in mental health disorders amongst people during the pandemic as a whole?
That's a good question. I think that's part of what everyone's trying to figure out. So we know rates of everything raised in both, right? The pandemic, higher rates of depression, anxiety, substance use, all these things were happening. Higher rates of problems with concentration and focus, right? ADHD requests evaluation requests shot through the roof during the pandemic. And it's like some of the very same diseases or disorders or symptoms that you see in long haul. I think it's just maybe all the factors feeding into it may be a little different. So not so much that the symptoms are different, but all the contributing factors are different. So in long COVID, thinking that there might be specific kind of neural inflammation from the disease process, there's this hypothesis about serotonin depletion, all these kind of things. That may not be why someone's depressed in the general population, but it might be why depression is harder to treat in a long hauler. That's how I think about it, is that you're going to see similar things in both. But I think, again, in the long haulers, it'll be part of a constellation. So they will also have other physical, whether that's clotting or breathing problems or cardiac issues. They're going to have a constellation versus just a pure depression that you might see in someone who didn't have COVID.
Right. Again, another excellent answer. Thida, could you tell us about the pathophysiology, i.e. the disease-causing process behind the mental illness of long haulers?
Yeah, I started to touch on that in my last answer, but it's pretty complicated. I think there's a lot of things still being looked at. Again, a big one is and has been from the beginning is inflammation. Before COVID came along, this was already getting looked at in the field of psychiatry because, again, some of these things are actually not new. I know it feels novel, this idea of a post-viral illness or inflammatory illness leading to depression, but we had seen that well before COVID. We'd seen it with other viruses. We'd seen it like in autoimmune disorders, endocrine disorders. Folks with chronic fatigue syndrome existed before this. So we'd already started to be like, what's going on there? And so I think there's this idea that COVID itself really triggers this inflammatory pathway, and that can cause damage on the neuronal level. So that's definitely one of the kind of big hypotheses in long COVID. And then I mentioned the serotonin depletion because they started to find there's recent studies looking at serotonin reservoirs in the gut, and it's hanging out there. And what does that mean? And this idea that COVID triggers deficiencies in tryptophan, and then downstream from there. And so that's why there started to be increased interest in antidepressants. Early in COVID, there's already this idea that folks who were on SSRIs were maybe less likely to get long COVID or had better outcomes in some ways in their COVID disease process. And so now, can you treat long COVID with antidepressants? Those are some of the hypotheses there. Then there's the ones that come from how sick were you? I know we're saying you can develop long COVID regardless of the severity of your COVID infection. I think we'll start to understand that in a more nuanced way because there are some differences. So if you're in the ICU to where you're hypoxic and you really couldn't breathe, your oxygen levels were really low, you needed to be intubated and on a ventilator, we know that inherent in and of itself can cause problems, right? There is injury in the brain and there are physiologic changes from not having oxygen. That can make you look depressed. That can make you confused or have cognitive impairment. Or if you were in the ICU and you got that hospital-acquired delirium or ICU delirium, we know that has residual cognitive and emotional impact and the medications you get. So there's that. I think it depends on your treatment setting, your comorbidities, all of that. But I do think it's going to end up somewhere in that realm of inflammation and some of these neurotransmitters. That just makes sense.
Right, thank you. Which group of people with long COVID are more susceptible to mental illness?
Yeah, there's been a lot of things looking at that too. And right now it's a pretty wide bucket. Here are all the things associated with long COVID. We see a higher prevalence in female sex versus male. We see a higher prevalence in folks who had a lot of like chronic medical conditions ahead of time. So if you, again, inflammatory based, so if they have things like diabetes or something causing high blood pressure, those sort of things pre-existing seems to make people more vulnerable. Pre-existing mental illness too. If you already had a history of depression and anxiety and trauma, that seems to predispose as well. I've definitely had folks all over the spectrum. I have folks with none of that who had long COVID, and I have folks with all of that. Anecdotally, I have seen that the more of those things you have and the more mental health history you've had, it does seem to take longer for the symptoms to resolve versus someone who really didn't have any of that and then developed new onset depression, anxiety, other physical symptoms after their COVID infection. I think jury's out, but that seems to be what we're seeing clinically.
Yeah, well, very interesting. So what psychiatric medications do you prefer and why?
That's a tough question because people come in, they come to see me, you must have something, right? You're the COVID psychiatrist. And I treat things similarly to how I treat other mental health conditions. I've talked about my evaluation stance and focus. I try to be really thoughtful about how all the symptoms fit together. So you're not going to see me throwing medications at symptoms that often. That doesn't mean I won't use medications to target sleep or anxiety, but I try to be like, okay, what is the quality of the sleep disruption? Why are you having it? What is the quality of your depression or your anxiety? Where is it coming from? How do these pieces fit together? And then I try to target that sort of formulation, as we call it in psychiatry, with medications. Someone will come in and say, I have brain fog. I won't go straight to a stimulant, for example. I get asked about that a lot. And maybe eventually I'll be outed as being overly conservative. That's being actively studied right now. But I'm just finding that it doesn't really do anyone's service, throw a med for every symptom. So I try to be, okay, you're having depression. Let's take a look at that. When we score you, does it seem to meet criteria for major depressive disorder? Is it more of a psychological depression from trauma? Is it depression because you're not eating well, you're on oxygen, your sleep's disrupted, maybe you have sleep apnea, and then I try to target the underlying condition. So if I do think it fits a major depression or a generalized anxiety or PTSD, I will use conventional antidepressants that I would use anyway. Sometimes I will lean more towards the activating ones if the patient also comes in saying, I really am so exhausted, having extreme fatigue. And so then I might reach more for fluoxetine, bupropion, activating ones like that. But in general, I try to figure out what's the side effect profile, what are the medical comorbidities, what does the patient also want targeted, and how can we collaboratively make a decision together. So lots of antidepressants happening in my clinics. I'll be curious to see what the SSRI studies say, because people are messaging me. Hard to say if they're progressing any faster than the folks I don't have on that. I will, like I said, use some sleep medications, trazodone, melatonin, things like that. If they're having trauma symptoms, I'll use prazosin like we do for trauma-related nightmares. And then occasionally I'll use stimulants. I've had a lot of patients where it turns out that they probably had ADHD all along. It just was mild enough that they could deal with it or compensate, and then COVID tipped them over. So I've used some stimulants in those, or if they have a sleep disorder, I might use modafinil or things like that. So really, I use a wide range. Also, yes, I've started using the low-dose naltrexone that a lot of people have looked into for things like chronic fatigue, inflammation, and we use like tiny, tiny doses to try to target that holistically. And some patients have really liked that, and some have said, I don't know if it's doing anything. So we try to do a combination of things.
Yeah, you're such a good psychiatrist. You really look at the whole person. It's just so refreshing.
I try.
And
It's hard.
no, it's great. And you've got such a sunny personality, I think just being around you is uplifting in itself. Could you please tell us about your group therapy services for long haulers?
We're really proud of our group therapy. That's one of our longer standing offerings and really some of our most popular with our patients. They're like, this is the thing. Yes, all the doctors, you all were great, but this group is really what's changed my life. And so we love that. So we have right now 2 different COVID groups, and those are the only long-term portions of our clinic. So we allow folks to stay in those as long as they want to and are actively engaged. Naturally, over time, some people get better, they get busy, and then we add new group members. We call them emotion-focused processing. So the idea there is to have a safe space where we have therapists and psychiatry facilitators. So they're there to make sure the group stays on track and is a safe space to talk about how are you feeling? What is happening in your life in the context of COVID? What's changed, not changed, and be able to talk to other people that get it, really, and share frustrations like, here I am dealing with long COVID, and there's my family member going out not masking and partying and doing all these things. Or really, what was fascinating was that some of the early things we learned about long COVID came from that group. I remember really early, some of my women patients being like, I'm losing my hair. And we hadn't yet written about that in the literature, that was a thing that could happen. So that's a sort of space happening there. And then we kind of introduce some skills, ways to cope with things like that. And then we have a chronic illness group that we had created pre-COVID, but lots of our COVID folks do rotate through that while they're waiting for a space in our other group. Because as you can imagine, we have wait lists for that as well. And we're so full that we are working on creating a third COVID group that'll be more time limited and more skill and knowledge based. So give people a foundation to work with while they're getting connected with other forms of therapy.
Wow, it's fantastic service. Could you tell us about the 2 different post-COVID groups and why there are 2 different groups? I noticed looking on your website that one is for people that have come out of ICU and the other is for people that have been hospitalized or non-hospitalized, so that you separated them. Is there any reason for that?
Yeah, so early on, when no one knew anything, that's when we were starting these groups. And we were first experiencing the wave of folks who have been in the hospital for quite a long time. And then we started to see more patients who hadn't been hospitalized. So that's where we started with the ICU hospital level group, because that was the patient population at the time. But we kept it going for a few reasons. I talked earlier about things like medical trauma, ICU delirium. And so we wanted everyone to feel their experiences were valid. We wanted them to feel other people in the group understood them. And as you can imagine, these are very different experiences. And so for our folks in the ICU, they're talking about near-death experiences. They're talking about intubation. They're talking about being months in a hospital. We've had some patients who required lung transplant afterwards. And we wanted them to be able to share that freely and not be, but also to have patients who didn't have any of that, but are still suffering, not feel, oh, I can't say anything. I wasn't as sick as them. So we felt they just had actually different experiences, different rates of recovery, different goals early on. That's why we keep it separate. And we felt that was the right way to go.
Great, thank you. I could talk for hours and go into more detail, but we don't have that much time. Given that access to programs like yours is low, do you have any advice for how someone with long COVID should approach their family physician for treatment of their mental illness?
And this is maybe for both sides, for the medical practitioner as well as the patients, really from a place of collaboration and the mindset that everyone's doing the best they can. I've seen a lot of frustration and tension because everyone's just overwhelmed and no one knows what to do. Patients come in because they're scared, they read about this, they're hoping for care, and then they feel disappointed if their doctor doesn't know what to do. And then the doctors on the flip side, want to help. They're healers by nature, and then they get stressed and maybe distant even if they don't know what to do. This isn't a thing I've heard of. So everyone's struggling. So I always say, approach from this place of, I'm experiencing these things. Can you help me figure out what's going on? Or if there's any parts of this we can do something about? Because I think that's the part that's really hard, is the chronicity and the complexity of this, is that we may identify things and there still may be a long road to recovery. And so it's not really about finding the fast answer, unfortunately. It's about, let's rule out big, scary things. Let's identify, rule in or rule out things we can intervene on. Have you developed a new lung condition or heart condition? Or do you need physical rehabilitation? And then we have to really be comprehensive. So for the patient too, knowing that the treatment plan to get back may be pretty comprehensive and very rehabilitation focused as opposed to like cure focus. And then knowing that it's a process. And you can ask your GP or family doctor, do you know of any place where I can get a second opinion or a consultation? And then we can continue working together on how to manage this.
Do you have any advice for family physicians on how to manage mental health amongst long haulers in the community, and when not to initiate medication?
Yeah, so the flip of what I was saying earlier, but I think it's really about, again, you have a lot of training in mental health, and so I don't want you to feel like you don't have what it takes to treat long COVID. But I think, again, it's really about figuring out impairment. If you're unsure of the level of impairment, are there objective ways to test for that? So you don't want to jump straight to like neuropsychological testing. That's a very limited resource. But if you have someone who was maybe previously a doctor doing ER shifts, and now they can barely manage their bills, and you're trying to figure out, can they go back to work, or figure out why is their impairment so significant? They had COVID for 1 week, then that might be a time to seek out additional ones. Again, but if someone's on the road to recovery, I think that's okay. You can just be there on the journey with them. You don't have to seek specialty care. So I really think that's the kind of thing. What is the trajectory of recovery? What is their level of impairment? And the same thing for initiating mental health treatment. What is their level of impairment? Are they getting better? Are they not? Is their mental health contributing to other parts of their care, which we know it does. So if they have brain fog and depression and anxiety, you want to optimize treatment of the depression and anxiety, not because you expect that to fully cure the brain fog, but it's going to help, right? So that kind of thing. Is the mental health symptoms or conditions feeding into other parts of that whole picture? I think, again, leaning heavily on resources like this to try to make sure you're doing this level of workup. And then once you've exhausted it, then you'd be, okay, I need someone else with new ideas to come help us out.
That's excellent answer. So you talked briefly about an ECHO project. Are you going out into the community now and training GPs in your area on how to manage long COVID, how to diagnose it? Is that what you're doing?
Yeah, and so the ECHO program existed well before me. It's managed by a lot of people, but the whole goal there is community outreach, education. So whether that's community, whether that's primary care, all of that. And it's these sessions people can sign up for, they're free, they're bite-sized, and trying to target really high yield things. And how do you do this in primary care? So yes, there have been COVID-related ones. There have been ones in connection with the CDC. We're working on some new modules now, actually with our Colorado local program to offer this virtually. And so I think that's what, there's a lot of it's coming out there now. And I mentioned that with the American Psychiatric Association, we put out a guidance document as well just last month to help guide psychiatrists in general with how to do this. So again, just trying to make this something so where every kind of doctor you encounter has some level of comfort and knowledge, even if it's not super in-depth.
Okay, great. So I'll include, if that guidance is in the public domain, I will include it in the show notes as a link. And yeah, please keep us informed of anything that we can include on the website for people to get access to. Well, thank you, Professor Thant, for such a wonderful interview and for taking the time to educate us and to share your experience of working with and for long haulers today.
Thank you so much for having me. It was great.
Please join us for next week's episode of Long COVID The Answers. Some questions for viewers and listeners to consider. What are your top 5 takeaways from this episode? How will this episode change your practice or perception of this disease? What will you do to act on what you've learned? Please discuss your thoughts on our social media outlets, Twitter or X, the website blog, Instagram, Facebook or LinkedIn. Please rate this episode